demonstration of nasogastric tube insertion. I will have done my standard steps. For the purposes of the demonstration, we are not including those because we want to keep these little videos short. When you return your demonstration for CBE, you will be performing the standard steps. I have collected all of my equipment. I have an emesis basin. I have my client at a 30-degree or higher angle, and I have protected my client's chest. This happens to be Miss Florence Nightingale. My other equipment are exam gloves, my Salem sump tube, a flashlight, tongue blade, lubricant, tape, stethoscope, a feeding syringe, a cup, straw, and I do have some hand sanitizer here and a rubber band and pin. So the first thing I'm going to do is put on my gloves. And Miss Nightingale is not verbal, however, I will talk to her while I'm doing this. And primarily the discussion will be how to do this nasogastric tube insertion. So I'm going to check her nares first to see where I will be seeing this, putting this down. And I want to put it and choose the nares that will be the least obstructive because I do not want to do damage to the nares or that nasal cavity as I'm putting it down. The next thing I'm going to do is open my Salem sump package. This is a double lumen tube. And I will open this toward me. Although our GI tract is not sterile, it's definitely not clean, so in essence this is a clean procedure. The first thing I'm going to do is the next measurement, and that is measuring from the nose, the N, to the earlobe, which is the E. And then my suggestion is, because there's so many variables with this measurement anyway, that we briefly expose the chest so that we can see the sternum, because our X measurement is to the xiphoid process of the sternum. So we have nose, N, E, earlobe, X, Z, xiphoid process. So now I have an estimate, and if you do not, you can mark this with a small piece of tape at the xiphoid process. I see a 55, so that's how I know that's how far I'm going to be down. And I see a 15 here, so that's how I know that's how far I will be down to get to the back of the throat. The next thing I will do, and we're going to simulate this for the purposes of keeping our mannequins free of lubricant, I'm going to simulate lubricating the tip of my nasogastric tube. I will have, I'm going to insert this first, and let's cover her back up again here. I'm going to insert this first to the back of the throat, and once I am to that measurement that I estimated, I am going to check in the back of her throat to see if I can see the tube. And there it is. I can see it right in the back of the throat. Now I'm ready to insert it down into the esophagus. And in order to do that, I'm going to put her chin to her chest. And what that does is compress the trachea a little bit, because I don't want it in the trachea. If I'm into the wrong spot, this person is going to start having trouble breathing. So as I insert this, I will have her take a sip of water, and that swallowing will help the tube to go down. So I'm going to have her take a sip of water. I'm going to put her chin to her chest, and with every sip of water, I'm going to insert this. I think your CBE says 3 to 4 inches. So they're very difficult to get down on these mannequins, so I'm going to have her sip and insert. Sip and insert until I get it down to the mark of 55. So now when I feel that it is in place, I like to temporarily tape, because this tube is going to want to come back out again. So I like to put either the tape that I'm going to leave on there permanently, and I've done enough that I'm pretty sure that I'm down in the place. I'm going to make it, so I'm going to go ahead and tape it the way I would tape it finally. I'm going to make a pair of pants here. So I'm going to tear this, and the waist is going to go up on the nose. It's really nice if you do this ahead of time. Here. And one leg of the trousers is coming one way around the tube. And the other leg is coming the other way around. You might ask, would it not be easier to take your gloves off? And I might say it might be easier, but it would not be controlling infection that we might get from the patient. The next thing I want to do is check for placement of the tube. So I need to expose the abdomen of Miss Nightingale here, keeping her covered as much as I can, but I do have to see the whole abdomen. And incidentally, I have this Salem sump tube came with a clamp already in it. If I don't have this clamp in it, I'm going to probably be having gastric secretions secreting through that tube. So now what I want to do, and I've got my stethoscope already out, it is not hanging around my neck, because at this point in time, if it were, I'd have to take it off. I'd be contaminating my hair, I'd be contaminating my uniform. So I have this already out and ready, and I'm going to put my stethoscope in the left upper quadrant. And I'll show you a picture in class why we do it there, but it has to do with how the stomach is, where the stomach is lying in the abdomen. And I'm going to insert, and I believe your CBA says 10 to 20 mils of air. I like to use 20 because if you're going to be able to hear the air, or 10 because if you're going to be able to hear the air, you might as well just put in 10 because it's that much less air that you're putting into the client, Miss Florence Nightingale's stomach. So I will get my syringe ready. And what I'm listening for is a swishing sound. So left upper quadrant, swish, and I've got to push this pretty fast if I anticipate hearing it. And I hear a swish. On our mannequins, we do not hear a swish because I don't have this all the way down into the stomach, and we probably couldn't hear it anyway because of the way the mannequins are built. So I've heard a swishing sound now. I'm going to put my stethoscope back over here rather than laying it on the bed because then I will have less to clean when I'm all done. After I have checked I've heard the auscultation, I'm now going to aspirate and check aspiration, and this will tell me a second check of whether I am in the stomach. So as I pull back, I'm expecting to see here yellowish, greenish fluid that would be stomach contents. If this person has eaten, which chances are they haven't, and that's the reason we're putting the nasogastric tube down, I would see just gastric secretions. However, if they have eaten, I'm going to be seeing some stomach contents here too. So I've auscultated to be sure it's in place. I can presume it's in place when I do that. When I've aspirated, seen some stomach contents, I can presume it is in place. I'm going to refeed those stomach contents because it will have electrolytes in it and stomach acid, and I don't want to lose that for the client. When I take this out, I'm going to clamp my tube because I don't want it secreting, and then I will re-put my clamp in, which I have lost in this. Someone is seeing it. Thank you very much. If I couldn't have found this, eventually I would have had to look for this because I do not want it laying in the patient's bed. If the patient lays on this for any length of time, I could have a beginning of an excoriation and or an open wound. If I hadn't been able to find that, I would have just put this back into pocket. All right, so at this point in time, then I know this is in place, and I will either clamp it or I will attach it to suction. It depends upon why we have put this tube down. This Salem sump tube has an air vent on it. And the purpose of the air vent is that if we were to connect it in suction, this would help to equalize the air from the outside so that we're not just sucking on the stomach wall and causing irritation there. It's important for us to always keep this pigtail air vent up above the level of the stomach. So many times our patients are unconscious and we can just lay it on the bed. We'll keep it up here. We can tape it, probably not so much to the gown but to the bed. Rubber band is another way we can do it pretty easily. I think with the times that you want to be concerned about it is when they're going to the shower or being bathed or being turned. Always from now on, this patient's head, when a tube is down, will be at least at a 30-degree angle. So if you see a car, you're at the nurse's station and you see a car going by to the shower room and it's lying flat, you need to see that it's raised. Let your STN know that we do need to get that up. You can go over and raise it yourself and do a little education with your STNA. Let me see, have I used all of my equipment? I believe I have. I will clean, use a sanitizer on my hands, and I'm going to clean my stethoscope so that I can go ahead and use it on another client as I move. I'll leave Ms. Nightingale in a comfortable position and discard my biohazard bag. I'll clean my stethoscope, and I had my pen out already so that I can document right away in my treatment book that I have done this. And I will probably write a nurse's note about this also. And what would be the response of my patient to this is, of course, how they tolerated us getting to down. We're gonna, she did not move at all. There were no nonverbal behaviors. She is nonverbal. But the other response that I want to be sure to document is, what were the secretions that I withdrew? Did I hear the swoosh in the placement? My action is simply that I inserted a nasogastric tube per the physician's order. And I would believe that would be the end of this demonstration. Standard steps, of course, which we are not going to include at this point in time.